Welcome, everyone. We'll get started in a moment. Welcome, everyone. We'll get started in a moment. On behalf of the Centers for Medicare and Medicaid Services, Division of Tribal Affairs, I would like to welcome everyone to an All Tribes webinar. My name is Nicole Pino and I work for Kaufman & Associates, and I'll be your moderator today. Today's webinar is titled All Tribes Consultation Webinar on Medicaid Coverage of Traditional Health Care Practices Provided at Indian Health Service and Tribal Facilities. Before we begin, I would like to highlight the main features of your Zoom webinar interface. First, the presentation slides will appear in the main window, while the speaker will appear in the top corner. At the bottom of your screen is the menu bar. Here you'll find the chat, raise hand, Q&A, and closed caption functions. Please use the chat box to report any technical issues you're experiencing. We'll respond to these concerns as they come in. Next to the chat box is the raise hand feature. You'll be able to use this during the Q&A segment to let us know when you'd like us to unmute your mic so you can ask a question. Another way you're able to submit a question is the Q&A box itself, where you can leave your questions at any point during the webinar for the presenters to address during the Q&A segment at the end. Lastly, live captioning is available for today's broadcast. Simply click the CC icon to use this feature. Please be aware that today's webinar is being recorded and that the recording will be made available online in the near future on cms.gov. Next slide, please. Please note that this webinar series is supported by a contract awarded by the Centers for Medicare and Medicaid Services. Next slide. So at this time, I would like to turn it over to Beverly Lofton.
Thank you, Nicole. Thanks for that welcome. Good afternoon. I'm Beverly Lofton. I'm a Senior Policy Advisor in the Division of Tribal Affairs, and welcome to today's consultation webinar. This webinar is in collaboration with the CMS Division of Tribal Affairs and the CMS State Demonstrations Group. During this webinar, CMS will provide an overview of the Section 1115A demonstration process and a high-level overview of the 4 pending demonstration proposals to cover traditional healthcare practices. CMS will discuss its framework for potential coverage of traditional healthcare practices consistent with the authorities in the Indian Healthcare Improvement Act. This webinar is being held as part of the agency's consultation requirement under Executive Order 13175 and the CMS Tribal Consultation Policy. CMS is seeking the advice and input from tribal leaders and webinar participants on the scope of coverage, recommendations on provider qualifications, and monitoring and evaluation criteria. A copy of today's slides will be provided to participants via the participant's email address provided at registration. We are pleased to be joined on this webinar by Group Director J.C. Cooper and her staff from the CMS Division of Demonstrations Group, CMS State Demonstrations Group. I will now turn the webinar over to J.C. to begin today's presentation. J.C.
Thank you so much, Beverly, for that introduction. You could take us to the next slide. So thank you all again. I'm J.C. Cooper, the Director of the State Demonstrations Group, and with me I have Kelsey Smith, a Technical Director in our area, and Kate Friedman, a Project Officer. I'll give the presentation, and then Kelsey and Kate will be participating in our question and answers later after we present. Next slide. So we have a really good understanding that every tribe has different practices and different ways they heal. We in no way are attempting to standardize these practices, but we are really excited today to walk you through our framework around traditional healthcare practices. We're also not trying to fit this into a Western framework or require validation of these practices. The process is solely to provide a framework for Medicaid requirements for traditional healthcare practices offered by IHS tribal facilities, while at the same time respecting the sacred and personal nature of many of these services. And we know that a wide use of these services have been deemed to be effective in many practices across our Native nations and over generations. Our goal here is really to recognize and support Indigenous knowledge and to improve timely access to these critical healthcare services. We also know that in our Medicaid outcomes, we've been identifying that American Indians and Alaska Natives experience significantly worse health disparities and culturally competent care, and aiding to address these disparities is a key goal of this administration to ensure we can improve health outcomes for all Medicaid beneficiaries, and in particular, American Indians and Alaska Natives. Next slide. We have been exploring, looking at 1115 demonstrations to cover traditional healing, or what we're calling today traditional healthcare practices, for quite some time. We know there have been a number of requests that have been pending with CMCS for review and consideration going back as far as 2015. We currently have 4 pending requests with us: Arizona, California, New Mexico, and Oregon. We are seriously looking at moving forward as many of these as we can within this framework. Each state has presented something slightly different, and so we are trying to look broadly across this for the framework, and we'll see if there are pathways forward for each of these states as we continue these conversations. In doing this consultation and building of the framework, CMS has had a wide variety of conversations with colleagues across the federal government to review these requests, including the Indian Health Services and White House Council on Native American Affairs. We've also been working very closely with Dr. Loretta Christensen, the IHS National Chief Medical Officer, and have discussed a number of the practices that would be available, as well as provider qualifications. We've also worked with the CMS Tribal Technical Advisory Group on feedback, and are now bringing this framework to a wider group for continued feedback and input, and really look forward to a conversation with you all today, your feedback, advice, and input as we are building this framework to be able to move forward. We are hoping to move forward on a number of actions this year for these states based on feedback in a number of settings. Next slide. So as we approach the framework, there's a number of things when we're approving an 1115 demonstration that we need to consider and document in what we call special terms and conditions. And that includes eligible beneficiaries, traditional healthcare practices, so which services are going to be available through the demonstrations. We also have to look at who are those that are providing those types of services. We need to identify the reimbursement and infrastructure potential options to fund and make this a viable solution across all of our tribal partners. And then one of the requirements in federal regulations is that we evaluate these demonstrations to see the outcomes from them. I would just flag dominantly as we're exploring traditional healthcare practices in this framework, this is really about making sure that there is a pathway forward for the reimbursement of traditional healthcare practices. In no way are we trying to dictate how or in what way the tribe provides traditional healthcare practices, knowing that that will vary greatly across all of our tribal partners. Next slide. So next I'll walk through who are the eligible beneficiaries that would be able to participate in our current framework. So currently we have included eligible beneficiaries to include any Medicaid beneficiaries who are eligible to receive services by or through an IHS tribal facility. Practices would be reimbursed at 100% service match, which is otherwise available for American Indian and Alaska Natives who receive services through IHS and tribal facilities. And as in other practices, American Indians or non-American Indians and non-Alaska Native individuals will also be able to receive these services like all other services by or through an IHS tribal facility. However, those services would be reimbursed at their respective match rate. Additionally, states can also choose to include coverage through the Children's Health Insurance Program, or what's also known as CHIP. Next slide. So as we are exploring not just the eligible populations, but what services would be allowable under the demonstration, we are looking at traditional healthcare practices that align with the Indian Healthcare Improvement Act, that are actively delivered by or through an IHS or tribal facility. And those are the various services that can be covered and reimbursed under this proposed framework. That does include traditional healthcare practices that are provided in the community by or through an IHS or tribal facility. And this is the part we wanted to stress here. That includes direct employees or contracted traditional healthcare practice providers. So one of the questions that we have been receiving as we've been providing feedback is this question around in the community, can these services be provided and reimbursed? And the answer is yes, as long as it is coordinated through either a direct employee of that IHS or tribal facility or a contracted provider for those services. That's really the hub of a lot of these of the framework is services by or through an IHS or tribal facility and populations that are otherwise receiving services through those facilities today. Next slide. So then as we start looking at the various providers and practitioners, we also want to kind of have a lot of conversation. There's been this is the area where we've had the most conversation. So we look forward to engaging with you all today in conversations in this area. But really what we're looking at is providers and practitioners that these services would be required to be employed or contracted by IHS or tribal facilities, as previously mentioned. Additionally, CMS is working with IHS to develop a high-level position description for general standards for practitioners. We want to flag, though, by no means are we trying to add any additional state licensing, credentialing, or other requirements beyond those which are already established by IHS and tribal facilities. So IHS and tribal facilities already have oftentimes ways of identifying who are providers who are eligible to provide traditional healthcare practices. They have, and this may vary from tribe to tribe, as well as the practices of identifying those who can do traditional healing or providing these services. And providers of traditional healthcare practices, are individuals who are qualified to provide those practices. But again, this is really determined by IHS or a traditional a tribal facility to do that. We have some questions that we would love feedback on when it comes to this. What kind of language should we use to refer to these healers or other individuals? And what is the broadest way we could describe the individuals across the tribes? We know the variation of how individuals are identified to be qualified within tribes vary significantly across the United States and across tribes. So we're trying to understand how we can describe this in a way that captures what we are trying to do. Additionally, we know that most existing practitioners who perform traditional healthcare practices or traditional healing services are employed or contracted by an IHS or tribal facility. Or I guess that's our question. Are most going to be contracted, or are we narrowing in a way that you have concerns or things that you want to make sure we're tracking as we develop language and standards for this as we move forward? So those are things we would love to engage in conversations with you all and get that feedback as we explore the parameters of providers and practitioners for this service. Next slide. So one of the things that we have found to be very effective as we have explored new and precedent-setting demonstrations in other areas is this concept around infrastructure funding. And CMS will consider infrastructure funding to states to enable them to provide dollars and funding to providers to implement traditional healthcare practices. Although we know many of our tribal partners, IHS and tribal facilities are offering traditional healthcare practices today to tribal partners, oftentimes they won't have the various systems for reimbursement or tracking or payment and coding that's required to participate in a demonstration. And so we have seen that infrastructure funding can be very helpful for those types of system updates or staff training, or to even develop the processes that may be needed to ensure compliance with the parameters of the demonstration as we move forward. And one of the pieces that we would love any feedback or guidance on as we explore this is, do you feel like infrastructure funding to IHS and tribal facilities would be useful in standing up the various reimbursement or tracking requirements for traditional healthcare practices, and understanding if you guys think that would be an important thing for us to ensure we consider in these demonstrations moving forward. Next slide. As I mentioned earlier, one of the requirements of an 1115 demonstration is that we look at evaluation of those pieces. And that includes a number of things. It includes, getting through the approval of demonstration is the first step. But oftentimes in those agreements, there are a number of things that states have to do to actually be ready to implement. And there are sometimes additional approvals that are needed by CMS to be able to do that. For example, we'll often have states create a plan for implementation and a process for how they're going to monitor and evaluate the initiative. And this often takes several months to negotiate back and forth with the state to implement the policy. We also would encourage states as they are building those policies and implementation plans to fully engage with our tribal partners as much as possible through that process, and do that state consultation with their state tribes and entities to ensure that they're getting that feedback of how that implementation would work in their respective state, knowing that each state may approach the implementation slightly differently, but also in alignment with whatever framework CMS puts forward for consideration. Additionally, as we look at the evaluation, which is required, we want to look at things that would be assessing beneficiary awareness and understanding of the traditional healthcare practices being available to them as a benefit, as well as reasons for receiving the services or access to those services, the cost of those services, and utilization of the services, as well as quality and experience of care and beneficiaries' physical and behavioral health outcomes. These are typical things that we would be looking at when it comes to the evaluation, and really would look for input and feedback today. Are these the right things for us to be looking at when it comes to evaluation? And any thoughts you have on where we should focus our evaluation of traditional healthcare practices as we move this framework forward. Next slide. So there are some things that we have not been able to finalize in regards to the framework, and we want to be very transparent about that. Currently, we have not been able to, within the framework, include services provided at urban Indian health programs. We have gotten a lot of feedback and comments regarding this, and we are continuing to look at this and dive into it. However, at this time, it is currently outside of the framework, and do expect to hear comments and would love any comments or ideas around that as we continue conversations today. Additionally, the framework does not include services provided by non-IHS employed or contracted providers. And that would include services not otherwise delivered by or through an IHS or tribal facility. And so those are the things that we currently have not been able to fit into the framework at this time, but we're continuing to have conversations around that as we move forward. Next slide. So we really look forward to having a conversation today, hearing feedback and questions so we can engage on this. Over the next few months, we will continue to really work closely with states and tribal leaders to solidify our policy. We hope to approve one or more of the traditional healthcare practice proposals that I mentioned earlier by the end of this year. We're all actively working towards that. I know that this is a long time coming from that perspective. We also know that you may want to get back to us with responses. You may want to engage in conversations and have those and get back to us. So we provided an email address here. We would like any written submitted feedback by April 21st. We also encourage you to ask questions today or engage in comments today as well, so we can hear that feedback from you all. That is really important to us as we begin to finalize the framework and making sure we understand things that we should be thinking about or considering as we build this framework. And so now I will turn it over to our group to be able to go through the questions that you all have, and we're happy to answer any questions you have or open up for comment as well.
Thank you, JC. As she mentioned, this is our time for questions. So we'll first be addressing the questions already submitted in the Q&A box located at the bottom of your screen. So if you haven't submitted yours yet, please do so now or use the raise hand icon and we'll get to as many as we can.
One thing, Nicole, would you want to open it up to tribal leaders first before we go into any other questions? So can you open it to tribal leaders first so they can go first, please? Thank you.
Yes. We will open it up to tribal leaders. So if any tribal leaders are on the call and would like to be unmuted, feel free to raise your hand and we'll get to your questions first. And again, if you need to find the raise hand icon, it will be located at the bottom of your screen. You'll simply click the raise hand button and we will go ahead and unmute you so you can ask your questions. Again, we'll open it up first for tribal leaders. Perfect. We see a couple of hands raised. So Kiara, would you be able to unmute them, please? Perfect. We'll get started with Jessica. Tribal Leader Jessica Mosher, would you be able to ask your question? We'll go ahead and move over to Kristen Timbers, our Tribal Leader.
Hi, good morning from Alaska. My name is Kirsten Timbers, and I represent the Village of Solomon. I serve as the Vice President of Community Health for Norton Sound Health Corporation, located in Nome, Alaska. We are the hub of the region, serving 15 surrounding villages. And we have a 7-member tribal healing team, 6 of whom are tribal healers. All have a background in the medical field, either being past CNAs or community health aides. And the founder of our program is still with us. The initial training that happened for them took place in the Kotzebue region, although I understand that program is no longer operating. And since that time, we have developed our own certification process for our healers. They average seeing 4 patients a day. They travel around the region. It is completely self-funded through Norton Sound. We have a training period that lasts 1 to 2 years for each healer. And I think there's tremendous value in this program, and I'm really pleased that we have the opportunity to consider recognizing the significance of traditional healing methods within a Western medical system, because these practices that include body manipulation and traditional plants and medicines have been proven effective for a lot of ailments and pain management for thousands of years. So I just wanted to share those comments, and I'll also be submitting them. Thank you.
Thank you for your comments.
Thank you. So it looks like we do have another hand raised. We'll go back to Jessica Mosher, our Tribal Leader. Would you be able to unmute her to see if she's able to ask the question?
It looks like Jessica put in the chat or in the questions, that she's not a tribal leader, but she had a question that she added to the question and answer piece.
Perfect. We will go ahead and move forward, and then we'll come back to Jessica to answer the question. We'll move over to Walter Morello.
Hello, can you hear me?
Yes, we can hear you.
Great. Hello, my name is Walter Morello. I'm the CEO of Native Health, an urban Indian health program in Phoenix, and I'm a member of the CMS Tribal Technical Advisory Group. I want to thank all the tribal leaders who are on the call today and others who are interested in this expansion of services by CMS, and would like to provide a comment today in my role as the TTAG Urban Indian Health Program representative. We're grateful that CMS has created a traditional framework. We are deeply concerned, though, that CMS has excluded services provided to American Indian and Alaska Native beneficiaries at UIOs from the framework presented today and to the TTAG. UIOs are Native-run health programs, and we are a critical part of the Indian healthcare system. Nationwide, we serve patients from 500 tribes, and 46% of the American Indians, Alaska Native patients at UIOs are Medicaid beneficiaries. By excluding services at UIOs from this framework, CMS is allowing Native Medicaid beneficiaries in urban areas and saying that to receive less care, less access to traditional healing than their relatives who receive care at IHS and tribal facilities. And that's not equitable. It shows a significant lack of respect for the traditional healers in our communities who preserve the native knowledge and practice medicine, which is proven to improve the health of our people. It also limits the understanding by CMS of the isolation of American Indians, Alaska Natives in urban areas, and the need to have their culture enriched, surrounded by many other cultures within an urban area. CMS decision also shows little understanding how closely tribes and UIOs are working with the states to craft these 1115 demonstrations. I know that in my state of Arizona, tribes and UIOs worked with state Medicaid office for over a decade to develop our 1115 waiver. We are united in our belief that American Indians and Alaska Native beneficiaries should have access to trained traditional healers in all parts of Indian healthcare system. We request that CMS revise this framework to reflect the proposals which have been developed through tribal consultation and urban confer and include UIOs. I applaud CMS for recognizing the need to support traditional services. I appreciate that CMS is using the existing 1115 waiver proposals as a resource for creating this framework. Now I ask that CMS recognize the need for traditional services for American Indians and Alaska Native at all ITU points of care. I challenge CMS to find a pathway to include UIOs in fulfilling this important aspect to American Indian and Alaska Native healthcare. If CMS fails to do so, it's ignoring the voices of Native leaders who have been involved in developing these proposals across Indian country. Thank you again for the opportunity to comment, and I'll submit these as well.
Thank you so much for your comment. And I want to just make sure that you understand we are hearing you, we're listening, we are still actively working on finding solutions, and I really just appreciate your comments and all submissions and comments that you have provided even before today. And we will continue to take this back to our colleagues and continue these conversations. So appreciate your comments.
Thank you.
Thank you. We'll go ahead and move on over to Nanette Starr.
Hi, can you hear me?
Yes, we can hear you.
Good afternoon. Somehow I'm logged into a different Zoom. Ayukwi, Nakna Virginia Hedrick, not Nanette Starr, but Nanette is fantastic. Hi, JC. It's really good to see you and hear your voice on this. Hello from sunny Sacramento. I just want to echo Walter's comments, and then also wonder if you can answer a little more specifically. As you well know, California's proposal has in its previous iteration in a demonstration waiver and now in the CalAIM waiver has included urban Indian organizations and has acknowledged our essential role in the Indian healthcare delivery system here in California. And just want to ask, like, what are the mechanics of why urbans are a work in progress, why we are not explicitly included in this framework?
So I can start, and then I'll ask Kelsey and Kate, who've been working on this longer. And yes, very good to hear your voice and look forward to continue conversations. And I would say there are a number of the proposals before us that include UIOs in them. And so I think it really comes down to a number of different conflicting federal laws that we're trying to work through. But Kelsey or Kate, if you could add some more information or details around some of the things we're continuing to have conversations around. I think some of it also stems from the various match rates that are being explored that we need to better understand the connection to Indian Health Services and the facilities and how there's a structure there for the overall services that are going to be allowed. So there's a number of factors that we're trying to continue to look at for finding parallels to the policy that we're leaning on at the federal level to be able to improve in the framework. But Kelsey and Kate have been doing a lot of this heavy lifting, and so I'd love for them to also weigh in on any of the things we continue to explore and try to find opportunities to include our urban partners in this very important policy.
Yeah, I would jump in here. Thank you, JC. We are, as JC said, continuing to understand different avenues where we can include urban Indian organizations, such as those avenues through existing care coordination agreement pathways. A lot of this comes down to our proposed service match that we are trying to match traditional healthcare practices at of 100% FMAP. And I know that's a longstanding discussion and issue with urbans and CMS and federal policy. We don't want to have anyone excluded or not have anyone benefit from this program, but we are actively working to try and pursue those existing pathways that are available to include urbans when possible.
Thanks, Kelsey. So just so I hear correctly, I want to make sure that I'm hearing the question. The current framework that you're using is tied to language provided in the Social Security Act, which is the directive language to 100% FMAP, which is why UIOs are excluded. Is that correct? I'm seeing you shake your head.
That's our
Okay.
proposed framework right now. Of course, we're working with our general counsel and getting this through the finish line. So if anything on that changes, hopefully we'd be able to share that.
And how would this impact like the California waiver, which does not present this challenge?
Are you
So
saying,
I think our general
I just want to make sure I understand the question. Are you saying that you in the California request isn't specifically asking for 100% FMAP, and so you're wanting to make sure that all proposals are being considered? I just want to make sure I understand the question as well.
Yeah, thanks, JC. Well, the California proposal is not referencing this 100% FMAP. It's this proposal of expanding access to traditional Indian health, and it includes urban programs. So if CMS approves this framework, that would extend at this point. These are extreme challenges, and I don't think a care coordination agreement, just to be clear, will not solve the issue in California. This very dynamic, very large Indian healthcare delivery system. So just on record, that's not a feasible proposed solution for California. What will happen to California states who have proposals in that do include urbans?
Yeah, I think we'll have to take that back and continue to explore the UIO piece. We're hearing loud and clear, and we've gotten a lot of feedback around considering UIOs at their existing match and not only pushing for the 100% match. And so we are looking at that recommendation and consistent with others, providing that for us to consider and look at those things. And so we'll continue to look at that, and just want to acknowledge again, what Kelsey said, at no point are we trying to exclude anyone from this benefit, and we will continue to work with our general counsel on pathways forward, and appreciate you raising on this call the concept of moving forward with UIOs, not at the 100% match, but is there a pathway to continue to include them at the respective match rate that exists outside of that. And so we will definitely take that under consideration.
Perfect. Thank you, JC.
Thank you.
Perfect. We will go ahead and move on to our next hand that is raised, Aaron Smith. Aaron, you can go ahead and unmute yourself and ask a question. All right, we'll go ahead and move on to Rhonda Beaver. Rhonda Beaver, you will be able to unmute yourself to ask your question.
Yes, good afternoon. This isn't Rhonda Beaver, but this is actually, I'm just using her line here. This is Dale Beaver, second chief of the Musco Creek Nation. And I just wanted to back up just a second and kind of get clarification on something about the traditional healers. What exactly is the ask from the tribes about their traditional healers being a employee or a contract? Can we talk about that a little bit and get some clarification on the why on that?
Sure, thank you for your question. Yeah, every state has submitted a different proposal for how and what they would like to cover. We are trying to create a general proposal, general framework that states can fit in under at the current moment, so we can move forward with proposals. The administration goal right now is to hopefully approve something by the end of this year. Right now, what our proposal and our proposed framework looks like is to cover or to reimburse providers who are either employed or contracted by an IHS facility or a tribal facility. So that's not necessarily the explicit ask of the states. That's something we have proposed in conjunction, in consultation with our states, as a way to try to broaden who we're able to reimburse and have a sort of a framework to ensure that we're including as many providers as we possibly can.
So when you talk, where's the traditional healing aspect coming into that? So here you talk about states. So why are we talking about states and traditional healers in the same sentence? I guess I'm not completely understanding this framework.
I can jump in here if you'd like. So in general, Section 1115 demonstrations have to come in through a state or a commonwealth. So states have to submit requests to CMS in order to move forward with their demonstration or their project and seek federal reimbursement for something. So in order to get Medicaid to reimburse for traditional healthcare practices, a state has to come in with a request to CMS to pursue this reimbursement. So we have to work with states and with tribal nations, and states have to work with their tribal nations in order to pursue reimbursement for traditional healthcare practices. Does that help answer your question?
I guess it provides a little bit more clarity. You also have to, I guess you're assuming also that the state works well with the tribal nations. Whereas here in Oklahoma right now, we work with some tribes work well with the state. There's some state agencies that work well with the tribes, but we are a little bit at odds right now with the governor of the state of Oklahoma. And so, I kind of see the avenue where you're taking this, but just from our perspective, from the Musco Creek Nation, the state does not need to know who our traditional healers are. That's our business, not their business. And so, it's kind of a, I don't want to say catch-22, but you're asking us to provide information to the state in order for them to help the state get reimbursed, but using our information and our people and our traditional practices. So we don't want to rely on the state for any of that type of stuff. We never have, and quite frankly, we probably never will. So if there's a way to get around that, and we're just not having to go through the state, which is probably one of the things that we've been talking about for years now. I would like to see that happen, because I just don't see why we have to go to the state and try to help the state get to that point whenever, quite frankly, the state of Oklahoma probably doesn't care about traditional healing. So that's just kind of my thoughts on this, and I do appreciate your clarification on this.
Yeah, thank you. I understand it can be very complicated between states and tribal nations and the confluence of where this meets in Medicaid, right, which is a state and federal program. So we hear your concern. Hope to, hear more from your state and other states alike as these requests roll out.
I'd also add that because of the 100% FMAP or reimbursement for American Indian or Alaska Natives who are seen at an IHS or tribal facility, that money would go to reimburse the provider. So the state through, or the federal government through the state would be directly paying that facility, that provider, for providing that practice, that traditional healthcare practice. So just also wanted to add that piece in there as well, that the money isn't going to the state, it's going to the facility and the provider.
Perfect, thank you. I will turn it back to Aaron Sam to see if he's unable to unmute himself to ask a question. For time's sake, I'll go ahead and move over to Donovan. Feel free to go ahead and unmute to ask your question.
Bonjour, Donovan Indigenous, Mikrakun Sijishgo, Magiziga Makwendo Dame, Misquagami Zagaginin Donjiba. So my name, that's a traditional Ojibwe protocol introduction. My name's Donovan. I'm from the Bear and the Eagle clan. My name's Little Snapping Turtle, and I'm from Red Lake, Minnesota. Very happy to be here today. Thank you for taking the time and doing a consultation. I just wanted to ask a question, or I think echo the last comments on why does the state have to request the 115 demonstration and the tribe doesn't directly, or the tribe can also directly ask, or a tribe can directly ask within a state, or they have to have the state?
Currently, federal regulations require that a state's governor put forward a request for an 1115 demonstration. And so states are required to put forward these requests for CMS consideration. Okay, and second part to my question is, then is it because, I think it was Kate who mentioned, is it because of the pay and the way Kate mentioned the pay flows through from the fed to state to the tribe?
Yeah.
Okay.
So I can jump in here. So the way that Medicaid works right now is that it's a state federal partnership. And so the federal government puts in some amount of money, the state generally adds to that, and then that is how providers are reimbursed. For American Indians and Alaska Natives who are seen at Indian Health Center facilities or tribal facilities, that amount, that reimbursement is paid 100% by the federal government. And so that's sort of a nuance of Medicaid law, but generally the Medicaid program is run through the state. Each state has their own Medicaid program. And so when a state wants to in some way change their Medicaid program, they have to submit this 1115 waiver. And so when we talk about making these changes, with reimbursement, it, by virtue of federal law, it comes through the government. The state submits that application for an expenditure authority or a waiver, and then we work with the state to effectuate that change.
Excellent. Thank you very much. And one other question had just come up. So we have about roughly 18,000 tribal members. 7,000 live on the reservation and the other 11 live off the reservation. And we have a nice, pretty high populated population in the Minneapolis, St. Paul area. So we do have a mental health, behavioral health program down there. And it's our Minnesota Dizzy Wind Clinic, our wellness clinic. And just for clarification, we do get the encounter rate for the people that are tribal members we're seeing. But others, like there's NAC, Native American Community Clinic, IHB, in the metro, and this comes back to one of the first comments one of the gentlemen mentioned, I think from Arizona. that's like, it's very important that somehow we're able to help and assist or see our tribal members off the reservation. And if we can't as a tribe, then we lean on all these other programs and this traditional health, traditional healing opportunity is very important to reconnect who we are as Indigenous people. So that's more of a comment. But appreciate you ladies and your time in presenting and talking with us today. Miigwech.
Thank you. So before there's a couple more hands raised. I will move it over to Marilyn Begay. Marilyn, you can unmute yourself to ask a question.
Yes, good afternoon. My name is Marilyn Begay, and I'm from the Southwest Four Corners area. I worked for IHS several months ago when I left, and I'm really concerned about what and how they do traditional medicine, because I'm a traditional, what you would call a traditional healer, but only a small spectrum. But I also work with the Dinehatasi Association, and we license traditional healers, the chanters, and these chanters utilize the herbs, they utilize singing, they utilize many different herbs. So I'm sorry, I'm coming cold. So I was hoping that somewhere along the way, there would be a separate traditional healing clinic or something away from IHS, because it seems like there's only like one or two at each hospital, and they have to work with the whole community. Or maybe just raise the Medicaid. I know they are only allowed $300 a year to get, to receive traditional healing. So some of these people that have deeper issues, they need 5-day ceremonies, 9-night ceremonies, and those are not cheap. They're pretty expensive because you have to buy things and food, you have to buy all kinds of materials to pay this medicine man. So they're quite extensive and expensive. Somehow I was hoping that somewhere along the way, they would get more than $300 a month. I'm not sure if I'm directing, I'm not really directing questions, I guess. I'm not sure, but I just wanted to say that. Thank you.
Yeah, thank you so much for that comment. I would add here that every state right now might do something different, but this proposed framework is really to cover a more comprehensive set of traditional healthcare practices. And so right now, our proposed framework is that any practice, traditional health practice that an IHS facility or a tribal facility is offering would be reimbursed at 100% federal match for American Indians and Alaska Natives. And so that means that if, in your example, an individual needed, weekly services, or they needed, daily services for a, defined set of time, under our proposed framework, Medicaid would reimburse for that at 100%. And so there would not be a dollar limit in the way that you are describing. It would be what is necessary, what a doctor has prescribed, or what a contracted or employed traditional healer has deemed necessary for that individual.
Mm-hmm.
And actually, I would add one other piece as well, to your other point about that sometimes IHS facilities only have one or two traditional healers. We hope that over time, as we reimburse at 100% for these practices, that will help support IHS facilities and tribal facilities, and maybe they'll be able to bring on additional providers because they're being reimbursed. And if a state chooses to request infrastructure funding, that funding can also go towards helping bring on more providers. So we also hope that this can have more of a long-term positive impact as well.
Right. I think it'd be good to work directly with people that know about these ceremonies, because you can't do them at IHS. You have to do them at people's homes, and they have to be there like 5 consecutive days or more. So some of these ceremonies are extensive. The ones that they have currently at IHS is just 1 hour, 2 hours, and that doesn't help a lot of people. And they're left out with these services, some of these services that they need. Thank you.
Thank you, Marilyn. So at this time, I will shift over to our Q&A box to start answering some questions, make sure we're not forgetting those. And as a reminder, if you have any questions, you can submit the question in the Q&A box itself, where you can leave the questions at any point during the webinar, and we will go ahead and start working on answering some of those. I will start off with Rosario. Rosario is the Chief Operations Officer at the California Rural Indian Health Board. And one of her questions is basically on behalf of our membership, which she serves 59 tribes and 19 tribal health programs. We highly support 100% federal match and reimbursement at the Indian Health Service, all-inclusive rate. Also in support of these services, they provide traditional healing services made at or in through a facility that provides or arranges traditional healing services. She just wanted to make sure that I would go ahead and read her statement for her today. Rosario, if there's anything else that you would like to add, you do have the ability to unmute yourself. Otherwise, I will go ahead and move on to the next question. Perfect. Starting off with Situ, does this require state agency administrating Medicaid to also agree with the tribe regarding coverage? And does the 100% FMAP apply?
Yes, I think we already kind of answered this in some of these other similar questions. So this would require a state Medicaid agency to come in with a Section 1115 demonstration request in order for Medicaid to reimburse for traditional healthcare practices. And as Kate and JC said many times, that this would be reimbursed at 100% service match for the applicable eligible individuals.
Perfect. We'll shift over to the next question. Chris, just to clarify, a provider employed or contracted by the tribal facility would qualify for this program. Is that correct?
Yes, that's correct.
Thank you. Next on to Ryan. Hello, and thank you for your presentation. Over the past couple of years, Arizona has been defrauded over $2 billion from its Medicaid agency, AHCCCS. Bad actors capitalize on the state fee-for-service reimbursement for sober living facilities offering intensive outpatient programming. How will CMS ensure that the providers and practitioners facilitating traditional healthcare practices are vetted? And who will appoint a provider practitioner as a traditional healer? Again, in the past several years, holistic and traditional healing in non-Indigenous spaces have been areas of capital opportunity.
Yeah, our proposed framework details that we would like traditional healers and practitioners to be qualified as determined by IHS or Tribal 638 facilities. So tribes and IHS facilities would be making that determination as to who would be qualified to provide a traditional healthcare practice. So as long as the facility or IHS, tribal facility or IHS has some type of definition, agreement, determination as to who is a qualified practitioner, then they would be allowed to be a practitioner of these traditional healthcare practices. So it does put a boundary around, not any outside provider is able to provide and get reimbursed by Medicaid for traditional healthcare practices. Hope that answers the question.
Great, thanks. The next question is from Gail. If Alaska is not included in the states mentioned, will specific demonstration projects in Alaska be considered?
Yeah, thank you for that question. So as 1115s currently operate, a state must come in with a demonstration application or an amendment request in order to begin negotiations with CMS and get approval to provide this reimbursement.
Great. Moving on to the next question, Jennifer. When you refer to not including non-IHS providers, does this definition also apply to providers at a tribal FQHC or 638?
Yep, so this would apply to IHS and tribal 638 facilities as defined in the Indian Self-Determination Education Assistance Act.
Next question from Inder. Hello, and thank you for your presentation. Will these services be protected under the federal tort?
On that one, I think we'll need to take that back, but I appreciate you raising it, and we'll need to take that one back internally. Thank you.
Okay, thank you. Moving on to the next question from Aaron Sam. He would like to know more about the contract, but it sounds like we've already reviewed that during the presentation, so I will go ahead and move forward. Next question from Sean Terrell. When do you anticipate this 1115 demo option will be available to tribes?
So right now, any state can apply and submit a request for coverage of these practices. Right now, we have 4 in-house, but at any point, a state can come in, and we're always working with states. So if your tribe is interested, I definitely recommend reaching out to your state Medicaid agency and sort of communicating that.
Perfect, thank you. And I'm going to go ahead and shift back to the individuals who have their hand raised to give them an opportunity to ask questions. We'll go ahead and unmute Felicia. Felicia, you are able to unmute yourself if you would like to ask a question. I will go ahead and move on to Shirley. Shirley Kane. Oh.
Hello, can you hear me?
Yes, we can hear you.
Okay, hello. Thank you for the presentation. So I had a couple questions and I put them into the Q&A so you could, get them in writing. The first one I asked was, is it possible to amend the Social Security Act to include tribes in 1115 demonstration projects? Because I saw when I scroll down to B, tribes are a part of that, and does that only pertain to the funding mechanism? So is it possible to amend it so tribes can be included in that? So if they don't need to use states, they can do them on their own. So that's my first question. My second question is, will the in the evaluation piece, I'm assuming there'll be an evaluation piece. Will that evaluation piece utilize Indigenous evaluations? And then also can they do cultural assessments? Because I think if they utilize cultural assessment tools, they can assess wellness, especially for traditional healers, because from my experience, a lot of traditional healers, they really do help with the healing process. And I know a little bit about that because way back in 2015, we drove up to Sault Ste. Marie, and at that time, Harlan Downwind, he was a traditional healer back then. He has since passed, but he talked about how when he first started working there, the doctors would not defer or even refer to him. And so he said it took some time for the doctors from the clinic to start referring people to him and his associate, because they didn't understand how traditional healers worked. And he said it took, I don't know how long, but it took a bit. And then once they got going, he said he was like inundated with people, because they would, take him into sweat and they put him out for fast, and they do all kinds of different traditional healing methods with them, which worked. And so I would just propose that I think some kind of assessment tool like indicator to measure the progress of the clients would be really beneficial for them, because it works. And the other comment I wanted to make was SAMHSA just did a webinar, I think a couple of months back, and they were very open to changing the GIPRA, and that's really a lot of tribes do not like the GIPRA because it does not benefit the tribes either. So I would say CMS and SAMHSA should work together to address the substance use and mental health issues in Indian country, because this data is off the charts, and we really got to change what we're doing from all avenues, because our people are still dying in droves, and we still have unresolved health issues and trauma issues that we really need a lot of help with. Thank you.
Yeah, thank you so much for your comments. And we acknowledge that there are, and we have identified on our side, clear disparities amongst American Indians and Alaska Natives when it comes to behavioral health services. And a number of the proposals before us are very much targeting and focusing on traditional healthcare practices and tribal healing services or traditional healing services to focus on behavioral health aspects. And we'll definitely take your other comments into consideration on the cultural assessments and pieces for the evaluation. And we would hope that states would be working directly with their tribal partners to provide that feedback through the negotiation on those evaluation aspects. On your broader question around amending federal law, we will definitely take that back. I would just flag, that's it's hard to get amendments to the Social Security Act, as you would imagine, but just take your comments under consideration and appreciate you raising those forward to us today.
I'll just take a moment to remind participants that it is after 4, but we have extended the webinar for questions. So we are here until at least 5 o'clock. So stick around if you still have questions and dialogue. Thank you.
Thank you, Beverly. I will shift back over to the Q&A box to try to get through as many as we can today. The question I have next is from Candy. What level of training would traditional healthcare be required to bill for services?
So I think kind of what JC said in our presentation is we're not necessarily wanting to set extreme, like very detailed limits at the CMS level of what training would be needed. We would like IHS and tribal facilities to make the determination of what would mean someone is a qualified traditional healer. So we would ask that IHS and tribal facilities would develop those qualifications for training, or years of practice, or the methods in which someone learns to be a healer. Those would be established and determined by IHS and tribal facilities.
Great, thank you. The next question we did have come in is, can you explain how the 1115 State Demonstration Office will get through these applications when the office is behind on general the 1115 applications?
Yeah, I will take this one. Yes, CMS acknowledges that we have a pretty significant backlog of 1115 demonstrations before us. However, given that some of these requests have been with us since 2015, we are prioritizing the traditional healthcare practices as a key policy area for us to try to finalize this year, which is why we're engaging in consultation and hoping to bring as many of these proposals to approval as we can, depending on where we land and what states ultimately will agree to as well. So we are hoping to move these forward in light of that backlog and have prioritized this as a key policy area.
Thank you. Next question is from Patricia. How would reimbursement happen for tribal FQHCs with PPS rate payments?
So all of these payments would be through the all-inclusive rate, the AIR, but would turn it over to Kelsey or JC if there's anything you want to add there.
Yeah, and I think we can take a further look of how this would impact tribal FQHCs. Our general framework applies to IHS and tribal 638 facilities, as I said, defined in the ISTEAA. So as defined there and reimbursed at 100% FMAP at the all-inclusive rate, but we can take back that question as well.
Great, thank you. Next question is from Ali. Do we need to get it verified or authorized by CMS before we start offering a traditional healthcare practice?
Right. So currently right now, IHS or tribal facilities or any facility can offer that. But in order to get it reimbursed by Medicaid, yes, a state would have to come in with a demonstration request and CMS would have to approve it before Medicaid dollars could begin to flow.
Perfect, thank you. Next comment we have from Vincent. I do want to remind everybody that this webinar is being recorded and we will be posting it on cms.gov. I will go ahead and switch back over to the attendees who have their hand raised. I will leave it up for another opportunity for Rosario to go ahead and unmute herself. Rosario, you are welcome to unmute to provide an additional statement.
Can you hear me now?
Yes, we can.
Yay! All right. Thank you for your patience. Again, thank you for hosting this listening session. I think super important. Rosario Ariola Pro with the California Rural Indian Health Board, like was mentioned earlier. We represent 59 tribes and 19 tribal health programs throughout California. And I just wanted to add that CRIB is highly supportive of 100% reimbursement of traditional healthcare practices at the Indian Health Service all-inclusive rate, taking into account the various mechanisms that will get all ITUs there. As we know, tribal community members flow between tribal and urban Indian facilities throughout California. They receive great care through these various healthcare providers. And thus, this is really pivotal to ensuring continuity of care and ongoing access, especially for some of these most vulnerable populations. As you know, California has no IHS hospitals, so we're it. And therefore, we need our urban Indian partners to also get that reimbursement. So just again, want to emphasize the importance of getting that reimbursement. And of course, these services are life-saving. So we know that it'll benefit all who can be part of it. Thank you.
Thank you for your comments.
I will move over to Scott. Scott, you should be able to unmute yourself to ask a question.
Can you hear me?
Yes.
Oh, great. Thank you. Thank you, everyone. My name is Scott Atoli, and I'm the director for Native American Affairs with Presbyterian Health Plan in New Mexico. We are a contracted managed care organization with the state to provide Medicare services to Medicare recipients throughout the state, including Native populations. I am Native American. I'm Hickory Apache. So I have a couple of questions, and this has been a really interesting conversation because we often get asked by my counterparts at the state level about certain services that we provide. One of the things I want to start off real quick is for Marie from, I believe she's formerly from the Navajo IHS. She was referring to a specific dollar amount, and I think that's referring to what is known as a value-added service that managed care organizations offer as support for tribal populations to seek traditional ceremonies. Again, it's a value-added service that's outside of the regular Medicaid reimbursement. So just for clarification on that. The big question that I have is really, we're talking about the services and the providers that will provide these services. And the response has been that we're allowing IHS to sort of determine those. Now, given the diversity of the Native population in New Mexico, does each facility determine reimbursable services, reimbursable providers? Will it be different for each location, or are we going to look at something that is more generalized and area-wide? Meaning Albuquerque area-wide or Navajo area-wide?
So based off of the way that we've crafted our framework right now is that it would be based off of the IHS or tribal facility to make the determination of what the services they're providing based off of the qualified providers that they either employ or contract. I think there is some hesitancy on our end to define a scope of the traditional healthcare practices that CMS would reimburse because they differ and vary so widely by each tribal nation. So it's our goal to make this as broad as possible and place the, boundary on who are the qualified providers at an IHS or tribal facility and what practices are they qualified to provide. And those would be the practices that would be reimbursed for Medicaid beneficiaries.
Right, certainly. And that's sort of what I struggle with, because we've had this conversation with some of the tribal populations here, or my department has anyway. And really part of that is what those practices that occur out at Gallup Indian Medical Center or Northern Navajo Medical Center would not be the same as a facility that is offered at, say, Santa Fe Indian Hospital. And so if they're two different sort of tribal populations, that kind of makes it difficult, especially when we look at how they're going to bill. And when they talk about billing, that opens a whole nother can of worms in terms of how IHS bills using revenue codes and not getting any more detailed beyond that. So it can be a little challenging if we're going to set up our systems to be able to reimburse Santa Fe versus Gallup Indian, if they're going to be two different sort of services. So that's a challenge on my end. And then as part of that, one of the things that I've heard from tribal people is, well, they're getting Indian Health Services getting the full reimbursement. How much of that is actually going back to the practitioner, the medicine man, that kind of thing? And so that was just one of the questions that I've heard in the past. So, and part of that my observations up to this point has been just the challenge with diversity. Again, there's 23 tribes in New Mexico, but we have representation from nearly every federally recognized tribe in the state. And I have a very large population that is very reflective of the Native population across the country as well. So again, how we determine those is going to be very difficult. How IHS is going to reimburse and identify those is going to be difficult as well. And just really determining, who is qualified to provide these services. And you've answered this question already. But yeah, that's going to be another interesting sort of hurdle as this process moves forward. And then I also wanted to iterate, because this was mentioned early on, as a managed care organization, one of the things that we're doing to sort of explore reimbursement for some of these services is we've negotiated with an urban Indian health center here in New Mexico to provide reimbursement and this is sort of outside of the Medicaid circle, but we offer it for our members that go to the urban Indian health center for behavioral health services, and we've defined sort of a scope of codes that they can bill us for. that their traditional person there provides. And again, that's an urban setting, so it's a little different. So as long as they can bill within those defined codes that we've both sort of negotiated, it's worked so far. Although utilization is very low, it is something that we do offer for our urban Indian Health Center to support those services at that level. But if we go out into sort of the more community specific service units or clinics, then we sort of get that little foggy area of and some of my counterparts in my other divisions have mentioned this is, you know, if I'm a Pueblo and how do I get those service and that particular service unit does not get or does not provide, say, Pueblo practices versus another tribal practice. So it's been a very difficult challenge for us in terms of sort of defining how we want to get those reimbursements as well.
Yeah.
Thank you for those concerns, Scott. We hear you, and I think this is going to be a challenge and a transition for everyone involved in the process as we are hopefully able to move forward with approvals and hope like working hand in hand with our state partners and the Native nations will help to smooth out some of those bumps in the road.
Right, right. Thank you. That's all that I have.
Great, thank you. So at this time, because there are numerous questions in the Q&A box, we will only be answering questions from the Q&A box itself to try to get through as many questions as we can with the limited time we have remaining. So I will go ahead and move on to Jessica's question. Please clarify the providers and practitioners who would be employed or contracted by or through the IHS or tribal facilities. So for example, what if the provider is employed or contracted by the tribe, but not necessarily the health facility? Some of these traditional healthcare services may fall under our family services programs, community service programs, and or culture or humanities programs, and not through the health facility.
So at this point, our framework is specifically for providers who are either employed by or contracted by an IHS facility or a tribal facility. We hope that by offering this reimbursement and infrastructure funding, these facilities may be able to bring on additional providers. But at this point, our proposed framework are for those providers.
Thank you. Jessica also brought up another question, which was brought up earlier regarding evaluations. And again, evaluations are expected to assess beneficiary awareness and understanding of the traditional health practices, reasons for receiving these services, such as access to and cost of and utilization of services, quality and experience of care, and beneficiary physical and behavioral health outcomes. She is recommending that CMS review the Indigenous Evaluation Toolkit developed by the 7 directions with the support of the CDC Indigenous Evaluation Toolkit. So that was just a comment that I would like to read.
Yeah, thank you for that. When we work on evaluations, we work with our state partners, and we expect that states will work then with their tribal partners to create and develop these evaluations. But we appreciate you submitting the CDC document, and we'll definitely take a look.
Perfect, thank you. Next question is from Dora Lee Sanchez. She's enrolled through the Lumi Tribal Healer and Family Services Human Services Project Manager. Kelsey, would you be able to just reiterate the process for the state's request?
Sure. So states have to initiate Section 1115 demonstrations requests. They typically come in through the governor's office or through the state Medicaid agency. Sometimes that goes hand in hand with the state legislature. It just depends on the nature of the state. States would come into CMS with a Section 1115 demonstration proposal for reimbursement for traditional healthcare practices, and then we would consider that proposal along with our proposed framework. So if a state is interested in pursuing a demonstration for traditional healthcare practices, we would recommend that they reach out to us, their project officer, their monitoring lead, and then, of course, involve the tribes in their regular required consultation process in moving that forward.
Perfect, thank you. Moving on to the next question, Jade. If a state wants to pass a legislation to make this happen, what do you recommend they do when working with their state health department? Does a state have to make a legislative change before tribes hire traditional healing employees or contractors for the CMS reimbursement?
So each state has different rules around when they are able to submit a Section 1115 demonstration request. It really just depends on the state Medicaid agency. So that's going to be state specific. I would recommend if the state has questions on the process for submitting a demonstration request that they reach out to us and we'd be happy to help them with that. The second part of that question was make legislative changes before tribes hire a traditional healer. It's not my impression that a legislative change would need to be in effect for IHS to hire a provider. That's not what we're proposing here, but states may need to make a legislative change in order to submit a demonstration request.
Perfect. Not a question, but a comment regarding the training of traditional healers. Dorleen also mentioned that all the other healers she knows have gone through a ceremony to become an established healer. And of course, witnesses are always called for these ceremonies. So just a comment I'd like to read. Next, moving on to Terry. He is with the Denver Indian Health and Family Services, Colorado, and she agrees with Walter. We are the Urban Indian organization as well, and we do offer traditional services and work with all Native Americans. Again, we just have some reiterating some comments regarding to Walter Murillo's feedback earlier today. So I will go ahead and remove those comments. Loretta Jordan, she is concerned how Medicaid is supplanting treaty-driven IHS obligations.
Yeah, I think our, our goal here is, their traditional healthcare practices appear in the Indian Healthcare Improvement Act as a practice that IHS and tribal facilities are able to provide for the benefit of the people that they serve, right? This framework that we're pursuing is a way for Medicaid to pay for part of those practices that are not otherwise reimbursed right now through any type of federal insurance program. So we are hoping to help and supplement what is being provided right now as a value add for individuals who receive services at IHS or tribal facilities. And I think it's also important to note that this would just be reimbursement for those Medicaid beneficiaries, not necessarily paying for every single person to receive traditional healthcare practices through any other type of insurance plan that they have.
Next question from Lena. How does the budget neutrality work for traditional healing under the 1115 waiver?
Yep, so Section 1115 demonstrations are expected to be budget neutral to the federal government. So we're working with our state partners in understanding the approximate costs of what these requests would be, and working with our federal partners as well to ensure that they would be budget neutral to the federal government, meaning that they would not cost additional funds beyond what is already being expended or delivered to provide traditional healthcare practices.
Great, thank you. Jade did have another question, but also is not sure if you're able to answer this. But in 2023, the HR 6533 was introduced in Congress which includes the 100% FMAP at Urban Indian Organization. Is that still passing through Congress or has CMS support?
I don't know if we can speak on that at this time, JC, unless you have a better answer there. As of right now, that's not necessarily something that's enacted or that we're able to act on. But if it is something that gets passed through, we would follow all federal rules and regulations in terms of reimbursement.
Great, thank you. Next question, has CMS had discussions on the ability for tribes to be able to provide traditional healing services through a traditional healer outside the four walls of the clinic? I believe you had answered this question already, but would you like to just provide a quick recap for that?
Yeah, I think one of the things we would flag is it is why we're saying that they can provide them by or through an IHS or tribal facility, and that includes in the community as long as they are contracted or employed with that IHS facility and or tribal facility.
I'll move on to the next question from Jessica. For clarification, is it the expectation of CMS that the traditional healer, traditional healthcare provider required to get a provider number for billing, or can it be billed through the general facility billing number?
What I would say is it would be no different than how services are currently being billed from IHS or tribal facilities. We're not enacting to move any or change any of those current practices today.
Great. And a next question, is there a way to keep traditional healers' identities anonymous?
We'll need to take that one back. We definitely heard some of that sentiment earlier. I think we just need to verify we have certain provider regulations and requirements that we would need to consult with subject matter experts internally. So we will need to take that one back. Thank you.
Thank you. Next question, did you say that was under the section 1115 waiver? Is that statute or is that a CMS policy? Can you share the document in the chat? CMS should consult with tribes to develop a workaround. It is not congruent with tribal sovereignty or the support of tribal sovereignty. It is a great opportunity for tribes and our members, but it has to be something that can actually be utilized as well.
Section 1115 demonstrations are part of the Social Security Act, so that is in statute. We certainly hear the importance of working closely with tribes and respecting tribal sovereignty, and we are aligning with what's already in statute and in the Social Security Act.
Great, thank you. And I know our tribal leader Donovan had asked a question and made comments earlier in this webinar. But if we're able to, who can he contact to initiate conversation to start this potential opportunity? Through the governor's office, through Minnesota Medicaid?
Yeah, we would suggest contacting the Minnesota Medicaid department, and they can, assist with next steps.
Great, thank you. Next question, how does this proposed framework interact with the potential for IHS tribal facility care coordination agreements with UIOs and related received through guidance in SMDL 16002?
Our goal would be to leverage the care coordination agreements that are laid out in that state health official letter that already exists today. That is what we are hopeful in pursuing, but we understand that may not necessarily meet all of the needs of urban Indian organizations, but we would like to pursue those existing care coordination agreements as an opportunity here.
Okay, thank you. Sean Terrell did have a comment, not necessarily a question, but just wants to clarify that traditional healing services can be provided in the community, including people's homes. Amber is the next question. If our state is not on the list of the 4 pending requests, is now a good time to engage with our state in conversations about what the tribes would like to see in their demonstration?
Yeah, I think we'd say that any time is a good time to engage your state Medicaid agency. States, as I think we've mentioned before, can apply for demonstration coverage at any point. You know, obviously, it goes through an extensive process at the state level. It goes through public comment and tribal consultation at the state level before it even gets to the federal level. So it is a long process. And we know that states are certainly looking to, you know, what we're going to approve. And but we would certainly suggest that you connect with your state Medicaid agency if you're interested in this opportunity.
Thank you. And another great question from Stephen. What will tribes do if the state they are in does not cooperate with tribes to put forward a waiver? What would you recommend?
I would say you're always welcome to come engage CMS, and we're happy to have conversations with the state to better understand those types of dynamics. And so we always have an open door policy in regards to raising concerns regarding Medicaid access to services and coverage to our attention. And we're happy to engage in those conversations if that were to take place.
I have another question. Is the 1115 route the only path CMS sees for Medicaid to cover traditional healing, or is there another path such as the 1915B waiver or SPA?
Right now, pursuing a Section 1115 demonstration is the only path, as traditional healthcare practices are not necessarily reimbursable or covered under other Medicaid authorities. And Section 1115 demonstrations allow us to do just that. It just demonstrates something different that's not necessarily currently being reimbursed for or allowed under regular Medicaid statute presently.
Angela had a question. Do we have to have our own clinic to use this benefit?
So the services, the traditional healthcare practices would be reimbursed if they are provided by a qualified provider at an IHS or tribal facility, or by or through those providers by or through an IHS or tribal facility.
And just clarification, the provider does need to be credentialed through Medicaid, correct?
Yes, in order to be reimbursed, there are certain provider enrollment requirements that we're not able to change.
I would just clarify, though, we're not implying credentialing requirements. We will set within the framework broad provider requirements of how those individuals will be identified through the IHS or tribal facilities, depending on how that language lands in the framework for determining those processes, as IHS providers who will be the ones billing are already in alignment with those billing practices today with Medicaid agencies.
Next question from Stephen. Are you planning on putting traditional health practices into the AFA? And if so, if the AFA program is rural as an IHS facility, can a Tribe 638 contract or compact out the traditional health practices and put it under the supervision of the tribe?
I think we'll probably have to take this one back. I'm not sure if we have really dug into that question before, but I appreciate you raising it.
Next question from Sonia. Does CMS already acknowledge homeopathic or naturopathic providers at 100% FMAP services through an IHS facility?
We don't have our subject matter experts on the benefit side to be able to speak to what's currently allowable billing on that side. And so we may need to take that one back as well.
Great. Next question from Jacob. Will the reimbursement rates for traditional healing or healthcare services be the IHS all-inclusive rate, or would the rates for these services be established through the 1115 waiver?
Yes, these would be paid at the IHS all-inclusive rate.
Great. And Melinda doesn't have a question, but Melinda Marley is a board member for the Utah Navajo Health Systems Incorporated, and they're located in Utah. We are currently waiting for approval from Utah Medicaid for reimbursements for traditional ceremonies for Utah tribes. I hope your office can help to support in getting that approved. Next question from Cindy. Now that some on the call have provided sample information about how some ceremonies work and that some need to be performed for days in a row at someone's home, how would those services be covered under this plan? Could the IHS 638 facility have a list of pre-approved traditional healers out in the community that they can refer patients to instead of having to hire and contract traditional healers?
So I
So,
think,
yeah,
go ahead, Jason.
I was gonna say, I mean, I think for what we can say today, I think that we are bound to the pieces that we have in the framework, and we'll continue to look at this, but it does have to be through a contracted or employed individual through an IHS or tribal facility. And that includes in the community as long as they're an employee of or a contracted. I think one of the things that has come up in previous things, and we need to engage with our partners on the other side of our CMS is looking at how things are billed when it comes to multiple days or those pieces, as we would be aligning with general practices and billing practices that already exist within IHS today. So we'll need to take that back as well.
Great, thank you. Not a question, but a comment that I'd like to read. Tribes should be submitting for the demonstration projects, and it should be a requirement for the state to accept the tribe's demonstration project as part of their program. That way, the tribes are protected from the whims of the state and can ensure that their members can receive this benefit. I think further discussion with tribes needs to happen on this topic. I am not so sure that CMS couldn't arrange that with the tribes, given the vast flexibility afforded to the Secretary under the Social Security Act. Next question from Shirley. Will the demonstration projects utilize community engagement or community feedback so they can assess whether tribal folks are satisfied with the services they received? I submit the gold standard in Indian country is when the tribal constitutes recommend the project to others.
Yeah, absolutely. We expect that states will engage significantly with their tribal partners and communities, not just at the beginning of implementation, but throughout. And that's one of the reasons that our evaluations are very useful. We can glean some of this information from those evaluations, but certainly expect that states will continually engage tribal partners to hear what's working, what's not, and how to improve.
Great. Next question I'd like to read off is from Kevin. Would each participant in a traditional health practice that is group-based, such as a sweat lodge session, be reimbursed as individual encounters, or would the group session be reimbursed as a single encounter, irrespective of the number of participants?
Yeah, I think that's one what we needed to take back and just better understand what the current billing requirements and pieces are. Again, we won't be changing any of those practices. So however that is currently applied would most likely how it would be applied under these traditional healthcare practices as well.
Great, thank you. And will MCOs be mandated to participate? And will traditional medicines prescribed like sweetgrass, teas, and balms be reimbursable?
I think that's going to have to go back again to what is allowed on the IHS side, is that is what we are using as our blueprint for what is allowable. And so once we finalize that with our IHS partners, I think we'll have more insight into what is currently allowed under that framework.
Great, thanks. Next question from Allison. Is there a summary anywhere of the existing waivers submitted that is available from CMS? For example, listing out who is submitting for AIR versus FFS reimbursement and differences in requests. This may be a benefit for the review of tribes and other Medicaid agencies and potential frameworks.
Yes, if you look at the answered questions tab, I've included the link to a Medicaid.gov webpage, and I'll do it again as well, that you can see the list of all approved, pending, expired, any and all demonstrations that have come through CMS. You can see there, and if you click through each state and each demonstration request, you can see what the state has requested.
Thank you. And will IHS 638 facilities be required to offer a variety of traditional healing practices for the different tribes they serve based on existing demographics, such as Pueblo, Navajo Nation, Apache tribe, etc.? And this is from Cindy.
So the practice that the IHS or tribal facility would be providing would be based off of the traditional practitioner or healer that they currently employ. So as long as the healer practitioner, as determined qualified by the IHS or tribal facility, is able to provide that tribe specific healing practice, then that is what they would be able to be reimbursed for.
Great. I'm going to go ahead and read Elena Cronk's message. Elena Kronk, she's the Government Relations Coordinator at the National Indian Health Board, and she would like to know the details about CMS and IHS plan for developing the traditional healer position description for IHS facilities and the plans for tribal engagement in the development. Additionally, it would be helpful to know the plans for additional consultation once CMS has developed a full text draft framework.
Sure. So we are currently working with IHS to create a high-level example of what a position description would look like. We would hope that states would then use that and base the position description for that state off of that high-level example.
Moving on to Christina Diego, the Seattle Indian Health Board has integrated traditional health codes into their electronic health record system, and our preliminary data is showing decreases in suicide ideation, depression, alcohol use, and anxiety. So not necessarily a question, but a great comment. Next is from Sean. Our evaluation costs 100% FMAP.
So we can take back this question. Typically, evaluation costs are incurred by the state, and they would work with tribes in understanding the scope of the evaluation, but we can take that back.
I think we got through most of the questions, and a lot of them that are left open are the ones that you have already answered. But I don't know if you would like to take the time to reiterate how someone can go through the state needs to go through the process for the 1115 waiver demonstration. If you can briefly recap, I think that would help answer a lot of these questions in the chat.
Sure. So in order for a state to submit a 1115 demonstration, as I've mentioned earlier, they first have to go through their state level public comment period. This is normally a 30-day period for anyone in the state to weigh in on the proposal, and it lists all the various pieces of what that proposal would be and its impact on beneficiaries. And if there are tribes in that state, states also have to go through their own tribal consultation process. They then submit that application to CMS. CMS has its own 30-day federal comment period for states to weigh in on, or not just states, anyone to weigh in on. And then we begin negotiations with the state Medicaid agency, and we determine what an approved demonstration approval will look like and what is needed in order to support that, whether there's infrastructure funding that's necessary. And then once that's approved, the state begins to carry out that demonstration, and we work closely with the state throughout that period as they're doing their evaluation and as they're implementing the initiatives in order to ensure that everything's going according to plan. There's no big issues. Generally, demonstrations are approved for 5 years, and then at the end of that 5-year period, a state can come back and request renewal for another 5 years, either with changes or as is. So that's the general process for state 1115 demonstrations. We recommend that if you have further questions on what that process looks like, you reach out to your state Medicaid agency. And they have a lot of experts there, and they may be able to answer any additional questions.
Perfect. And clarification, is this framework available for all states?
Yes, our intention here is that once we are able to approve, hopefully, several states under this proposed framework, any state would be able to come in, request a similar framework, and we would review that demonstration, approve a demonstration application, and go forward with an approval after negotiations.
And what would be steps for tribes to take as far as to getting an 1115 waiver in their state if they weren't already listed?
Yeah, Kelsey.
Yeah, I think we've said this before, that tribes should reach out to their state Medicaid agency. They're also welcome to reach out to CMS. As JC said, we have an open door policy, and we would be happy to connect you to the right folks. But since these requests need to come in from state Medicaid agencies, they would be the drivers in submitting the requests to us.
Right. And then is there an opportunity open for tribal facilities that have undergone the 638 self-determination process?
So this would be applicable to IHS and tribal facilities, 638 facilities as defined in the ISDEAA.
And would the reimbursement rates for traditional healing and healthcare services, I think you already answered this one, it would be an IHS all-inclusive rate. And of course, we would have to take it back and loop back around as far as some of the questions that were asked earlier. Otherwise, I think we got through most of the questions. If anybody has any other questions that they would like us to read through, this is your opportunity to submit a question in the Q&A box itself. So on the bottom of your screen, you'll find a Q&A box. You can type in your question, and we'll be able to read your question next.
Also, does it look, I think we have one hand raised. Are we able to take that?
Sure, we could do that. Christina Diego, you are able to unmute yourself if you'd like to provide any comments or questions.
Sorry, that was, I made my comment beforehand that Seattle Indian Health Board had integrated our traditional health services into our electronic health record system, and I forgot to lower my hand, but thank you all for today.
We did get a question in from Jade. So what I'm hearing is that the legislation is not needed, and the state health department and tribes can just make it happen.
What we would emphasize, and what I think Kelsey said, to just re-say it again, every state has different processes. Some states may require that they pass legislation to submit an 1115, and some may not. Either way, the tribes would still need to work with their state partners to move forward with an 1115. So just wanted to make sure we clarified that.
Thank you for the clarification. So I'll provide one more opportunity. If you do have a question, feel free to select the Q&A icon at the bottom of your screen to submit a question. Or if you would like to provide a comment or during this webinar, you can raise your hand and we can unmute you as well. Question came in from Rachel. In Utah, we needed legislation, unfortunately, but we are one of the only states who legislators require state legislation for 1115 waivers. If there are no more questions at this time, I would like to send it back to Beverly Lofton for closing remarks.
Thank you so much, Nicole, and thank you so much for JC, Kelsey, and Kate for just a really productive conversation. Great presentation as well. Thank all the participants as well for all those great questions that you had. Oh my goodness, we had over 300 folks at one point. That's a lot. So I do want to again remind you that CMS is requesting that tribal leaders interested in submitting comments for CMS consideration in this review of the demonstration proposals to cover traditional healthcare practices. You can submit comments no later than Wednesday, April 24th. And we have it that you can send those to tribalaffairs@cms.hhs.gov. That's our tribal affairs mailbox. Again, that is tribalaffairs@cms.hhs.gov. JC or team, did you have any other closing remarks that you'd like to mention?
No, just thank you guys so much for providing such valuable feedback today and insight into this as we continue to build the framework for traditional healthcare practices. We can't build this without your consultation and your input and feedback. And so just really appreciate the amount of time that you spent with us today, providing that advice and feedback, and look forward to future conversations.
Thank you so much. So we'll end it here. Everyone have a great afternoon.